Okay. So again, don't really have an agenda for today. We can continue going through the PowerPoint and the workflows. Maybe we'll just do a quick overview of what we covered the other day. So we talked about regimen and power plan integration and the importance of that order that goes back and forth between power chart and scheduling, and how we try to maintain it for as long as possible within the process, so that if we need to reschedule after checking in, we can do that. So we have the order set to complete on checkout, and then we have a rule that runs that when the clinical orders are activated, that order is, the scheduling order is completed then. We talked about treatment calendar and the reason why we have treatment calendar, and the confusing manner of ordering and releasing scheduling orders, so that we can make sure that we have the scheduling orders we need early enough to actually get them into the schedule. This confusing looking visual that I made for you guys the other day actually turned out to be quite useful. I went to BC Cancer, I think it was yesterday, and I was talking to the BC Cancer folks and was able to show them this as well. I think it actually does show quite visually how the orders get to where they need to be when we need to have them. Right, so this was about the scheduling order configuration. This allows us to check in a patient and then still be able to reschedule that appointment, because the order doesn't go to complete at that time. Sorry, my kettle apparently is boiling. We talked about the new chemo accept format fields that allow the chemo clerks to more granularly manage those request lists, and we'll go through that a bit more today. So the BCC chemo booking date, so we know that all the requests come from PowerChart with their requested date and time, just like any other orders to scheduling. But because of the volume of requests and the limited space that Vancouver has, they need to more granularly manage those requests. So they look at each request individually, and they, through a number of parameters, determine when it will actually be scheduled. So whether or not it's a continuing treatment, so it has to be done on that schedule, that weekly or monthly schedule, whether or not it's a new patient and that new patient can wait a few weeks, whether or not it's an urgent patient, whether or not they have some guaranteed spaces for that type of patient on that day. So throughout all of those rules that they use today in case, they determine a BCC booking date, and they place that booking date in this field once they've determined what that is. And it's this BCC chemo booking date that they then, it's then determined that that's kind of like a soft booking. It will probably get scheduled for that day if once a date is in there. We talked about the chemo waitlist field, where they can use this to indicate that a patient's on the wait list for a particular day. So if a booking date, let's say March 1st, already has 85 patients on it, but the patient that the clerk is looking at really should be done on March 1st, they can assign the March 1st date to that patient and put it on the chemo wait list for that day. So it would have a booking date of March 1st, and it would say yes in the wait list. So that means that we want to do it on March 1st, but we understand that this is an overcapacity patient. And so then there's a triage process that happens on the BC Cancer side, where the clerk and the clinical nurse leader and the manager and probably a physician goes through that list and determines who is more urgent than anybody else. And so then they try to get these wait list patients into that day. There'll be cancellations, there'll be less urgent patients, etc. And then the final field, the reserved capacity field, we talked about how BC Cancer Vancouver had come to some agreements with a variety of programs at BC Cancer, whereby they would save spaces for their patients on particular days. So perhaps on Mondays, they guarantee that they will do 5 liver patients if there are liver patients that are requiring treatment on that day. And so we've created this reserved capacity field to help determine that. So then we can imagine that a request might have a booking date of March 1st, and it might have a reserved capacity of clinical trials patient or new patient or whatever the program is. I can't remember what all the drop downs are in here. So that means that this patient is guaranteed that date of March 1st, and so will not be moved because there's been an agreement that those patients would be done on those days. We talked about the...
Julian, can I ask you a question? Sorry. I missed that last little bit. So just go back one. So if once, I just want to make sure I'm clear. So BC Chemo booking date, once they put a date, like say I'm working as a chemo clerk, I put the ready for treatment date is March the 1st, right? So, and I actually go into the chemo smart, what is it called? Sorry, that the other one they go into, and I do find March the 1st, there's available booking for that day. So, and then I put that in that booking. So then that date is reserved for that patient.
Right. It's kind of soft booked on that day. Yes. So there's every intention that that patient will be booked on that day. Now, there are some scenarios where the patient might get bumped, right? So today's February 19th. Yeah. If we assign it March 1st, then something might happen within the next 2 or 3 weeks, and that patient might get bumped maybe to March 2nd or March 3rd. But usually 80% of the time, once they're given a booking date, that will be the date.
Okay. No, I just want to confirm that. Thank you.
Mm-hmm. Right. And then we looked at the request list inquiry, excuse me. And we talked about how we have a new inquiry for systemic therapy. This Onc Systemic Therapy by Location inquiry looks at the request list that the requests drop onto by location, but then also has some other filters that can be used to manage the request list. So a clerk can look at all of the requests that have only been assigned a booking date of March 1st or March 2nd or whatever the date is. They can look at only requests that are on the wait list. And it's a multi-filterable list, meaning that you could select March 1st as the chemo booking date and yes as the wait list, and then it would display only those requests that have been assigned to March 1st and are on the wait list for that day. So on and so forth. We can look at all the patients that are assigned a particular date that have reserved capacities of a certain type, or if they are new patients, meaning that it will show only the cycle 1 requests if this is selected as yes. And then finally, the dual modality. Some sites have dual modality clerks and some sites do not. So a site that has a dual modality clerk could come in here and sort them to look just for the dual modality patients and then could manage those. So that would be a site-by-site decision. We talked about how CASE has some limitations. Well, Cerner has some limitations that CASE doesn't have. So they have some functionality in CASE that we're not able to replicate. Primarily, we can't limit the number of patients that are assigned a booking date for a particular day. Because we're dealing with requests that aren't actually booked appointments, we have no way to limit how many requests get assigned a particular booking date. So we've determined, or we're helping BC Cancer come up with a process to help manage that. And this was the way that we thought that we would do it, that there would be a spreadsheet or a chart on the wall that would indicate to clerks how many patients should be booked on a particular day. So in our example here, I just picked 30 for weekdays and 20 for weekends. BC Cancer will determine their own numbers. So this means that on this day, the clerk should, each booking date assigned should only have 30 patients in it. So if you filter a request list to a booking date of March 1st, then only 30 patients should be assigned to that particular date. We went through the on-treatment workflow, and we'll go through that a little bit more today about how a clerk goes through the request list, finds the request at the bottom of the list that doesn't have a booking date, and all the questions they ask themselves to get through the process of booking it. Do they need to change the nurse and chair time based on the special instructions? Then they can assign a BCC chemo booking date. They need to look forward to see when the next available free date is, which date doesn't have more than 30 patients on it or more than their limit of patients on it. If they want to assign it to a date that is already full, then they can use the wait list to do that. We talked about the ready to treat date as well. So the new patient request management is similar in that they go through those same questions. Do they have to update the nurse and chair time? What date can they assign it? Would they put the patient on the new patient wait list instead because they don't have any slots available? And then the documentation of the ready to treat date, that creation of the pre-recurring encounter before the appointment is actually booked, which is a break from enterprise workflow. So they actually create that recurring encounter at the request level so that they can document the ready to treat date. We talked about the ready to treat date being the date on it's the requested date and time on that cycle 1, day 1 request that comes across. We talked about multi-day cycle management, about how some cycles and some protocols have multiple days of treatment, and that when that cycle is signed or released from treatment calendar, that we would get 4 requests from the scheduling orders, and that they need to be booked in the order that they are received. So we have to book them in the date order that they're received, and they have to maintain their distance from each other, their timings from each other. So if they are day 1, 8, 15, and 22, then it has to be every week that they are booked. If they are day 1, 2, 3, 4, then they have to follow each other 1, 2, 3, 4. We talked about rituximab scheduling and how it's different because we needed a different order for that. So it's a separate order. And why we need a different order is because in some sites, they do both appointments on one day. They do regular chemotherapy and rituximab on one day. And then at other sites, including BC Cancer Vancouver, they do them on 2 days. So we need one appointment for one day and one appointment for the next day. We talked about how the rituximab appointment request will come over with a duration of 5 minutes because the duration of that appointment varies based on a variety of factors, including whether or not it's done on the same day as the regular chemo, whether or not the patient is receiving it by IV or subcutaneous, and whether or not they had a reaction previously. So there's information in the special instructions that helps the clerk make those decisions. So they're given the special instructions and then they need to go to PowerChart and look up that administration method and figure out what the duration is and then update the appointment request appropriately. Okay, so this was my note to myself as to how far we got the other day. Does anybody have any questions about what we covered already? Did you stay up late at night thinking about it and coming up with all kinds of questions, or did you just forget it all?
Me, Jillian, Anoop. So I actually felt a lot better after your demo or whatever yesterday, because I'm going to be really 100% honest. I was having a few sleepless nights over this before the demo. Yeah, so I thought that, but I actually, I actually did. I didn't have that much time, but I did go through it. I did. The hardest part for me was actually putting in the orders. I got stuck putting in the orders for the chemos, right? Yes, right. One of the instructors helped. I had to wait till next day till the instructor helped me there. So I actually did do the first part. I didn't realize you were going to do a demo, so I sort of have an idea now. So I feel a little bit of relief, a little bit of a plan in my mind. And unfortunately, I lost a couple of hours of work this morning. So I didn't realize you were actually going to do a demo for the go through the request list and stuff. But if you're going to go through the there, I actually added a couple of patients. If you want to use one of my patients,
okay.
Yeah, then I'll take screenshots and that. But I have actually, so I may interrupt you because I actually had quite a few questions while I was doing it. Okay.
Okay.
Okay, thank you. Yeah.
Okay, let's just.
All my patients have a last name of scheduling.
Scheduling, okay.
Yeah.
We'll have a look in a second, yeah.
Yeah, that'd be good.
Anybody else have any questions? Okay, there's just a few more kind of outlier scenarios in my PowerPoint that I just wanted to touch on. Dual modality is the first one. So dual modality, the scheduling of dual modality chemotherapy is really no different than any other request that we get. The only difference is that, of course, that they're receiving radiation therapy at the same time or on the same day or in the same time frame as the chemotherapy. So there has to be a coordination between the chemotherapy clerks and the radiation clerks as to when all of that is going to happen. So the only difference is that that dual modality flag exists, and probably you know this from if you've done any work with radiation therapy. So I believe the workflow is that the patient sees the radiation therapist, and then the clerk books the radiation therapy and flags the patient at the patient level with a dual modality flag. So it's in PM office at the patient level that the flag is set. And what it does is it allows us to do some request list sorting. So we saw earlier where I have a filter on that inquiry, so you can filter it and show only the dual modality requests. And it displays a warning when booking ST or RT appointments. So when you go to book a systemic therapy or RT appointment, or you try to reschedule one of those appointments, or you try to cancel one of those appointments, if the dual modality flag is set on that patient, a warning will come up to alert the clerk that it's a dual modality patient. It doesn't do anything more than that, and it just alerts the clerk that it's dual modality, and so then they have to go about coordinating those appointments with the other modalities appointments. So they would talk to the RT clerk and make sure that the chemo is scheduled either before or after or whenever that is appropriate for that particular protocol. Now, there is a potential issue in that the dual modality flag might be set after the regimen is signed. So it could be that the patient sees the radiation oncologist, they decide they're going to do dual modality, but that flag doesn't get set right away. And then the patient sees the medical oncologist and they determine what protocol they're going to put them on, and they sign that regimen and send across the appointment requests for the chemotherapy before the dual modality flag is set. So that means that that request won't have the dual modality flag on it on the request list. Now, there are some clues as to what a dual modality request looks like. So the power plan name is a Q. Most of the power plan names for dual modality end in the letters RT for radiation therapy. So that's a clue. And then most of the special instructions on those requests also say dual modality. So the chemotherapy clerk would be alerted that they are dual modality appointments, even though the dual modality flag isn't set. Now, fortunately, the workflow will then continue. The radiation therapy clerk will eventually assign that dual modality flag, and everything will go back to normal. It retrofits that flag. So then if anybody tries to touch the systemic therapy appointment request, book it, cancel it, or reschedule it, that flag or that warning will fire just as we would expect it to. So we don't have to do anything extra to kind of catch up to that flag. And there is a workflow for that as well. Yeah, dual modality. About when the orders are placed and when the flag is placed and what that means. Now the research and clinical trials appointments, I think I haven't updated. Oh, I did update it a bit. So we're still working on clinical trials. It's a work in progress even today, but I think we have it mostly nailed down. But it does work in kind of two different workflows depending on where we're at in our build. So clinical trials has a number of power plans in place for their work, like in the hundreds, I believe it is. And so there's been an agreement between CST and BC Cancer that we would build about half of them ready to go live. These are extremely complicated power plans that I'm not part of building, thank goodness, but that's why we can't get them all done. So we've committed to doing half of them, which means that we're kind of in a place where we will be doing some things on paper and some things electronically after go live. So we have an electronic regimen power plan, just like we might normally have a power plan, and then we have these paper-based PPOs that we need to manage as well. So we have two workflows to manage. So the electronic one is fairly straightforward. It's a regimen, just like any other regimen. It contains the same scheduling orders that we would expect to see in a regular chemotherapy regimen. The only difference is that if that Onc chemo infusion request comes from a research power plan, it won't land on the regular chemotherapy request list. Instead, it falls on the research future request list. This is because they have dedicated clinical trials or research clerks who manage all the appointments for clinical trials patients. And so we've routed these requests specifically to their request list so that they can coordinate all of the work that needs to be done for that. Now, once the request drops to the clinical trials request list, they have a workflow where they go through the same type of process as the chemo clerk would. They still need to assign a BCC chemo booking date. They still follow the same rules as far as criticality. They have some reserved capacity slots. So they have reserved pieces of the day every day that they can book patients into. And that's what allows them to get their patients booked ahead of other patients. So once they've done that, they've assigned a BCC chemo booking date, they've assigned a reserved capacity slot, then they have to move that request back onto the regular chemotherapy request list. And that's for Chemo SmartBook, which is what we're going to talk about in a little while. Chemo SmartBook takes an extract only from that regular list. So that request, the clinical trials request, must end up on that regular list. Once that's done, everything else works as normal. It goes through Chemo SmartBook that we'll talk about soon, and then the chemo clerk books it, and that's all done. Now, the paper-based PPO is just a tiny bit different because, of course, we don't have a regimen that's going to get signed. But because of Chemo SmartBook and having to send these requests to Chemo SmartBook for optimization, we do need a request for it. So from a paper-based PPO, what will happen is the clerk will receive the paper orders like they do today, and they will go into scheduling and create an Onc chemo infusion appointment request for each appointment required. They'll mark it as research study equals yes. They'll enter the nurse and chair time that comes from the paper PPO. They'll assign a booking date just like they would normally, and they assign it to the regular chemotherapy request list to make sure that it goes through that Chemo SmartBook process. So really the only difference is how that request gets created. In the electronic world, it gets created by coming from the order in PowerChart to the research request list where the clinical trials clerk manages it and puts it on the regular chemo list. And in the paper-based world, the order comes from a paper order. The clinical trials clerk creates the request and puts it on the regular chemo request list.
Jillian, it's Val. I'm just not sure what that looks like. How do they create the request?
Oh, we can look at that in here.
Could you just, yeah,
so,
would you mind?
Yeah.
Thanks.
So if you go in here, good.
Oh, I do know this, of course, when it's in.
Okay, we'll just quickly go through it.
Thank you.
So the appointment location is VA chemo. It's Onc chemo infusion. You have to fill in all of the same details that you would fill in for any other appointment. Normally this comes from the order. And then they move it to the work in progress, like they're going to book the appointment. They assign the chair time and the nurse time according to the paper PPO that they have in front of them. And then once you get it in the work in progress here, instead of booking it to a slot, you can actually create a request. So here it automatically is assigning it to the Onc Systemic Therapy Future Request List. And so now as soon as you click OK, instead of booking an appointment, you've created a request on that request list.
Awesome. I think I knew that way back when. Thank you.
I know it's a tiny little nugget in there somewhere. Okay, but we have one problem with research or clinical trials. Oftentimes, what happens is that the patient qualifies to be part of the clinical trials. They go through the entire screening process. They're allowed to join the clinical trial. The physician cancels their regular standard of care and then puts them on a clinical trials regimen. That's how things work. But because of the way clinical trials work, of course, the idea is that nobody knows what regimen you're going to be on, right? This whole idea of double-blind studies and randomizing patients so that they have a pool of patients, they have a control set of regimens, and then they have the clinical trial set of regimens. And sometimes they haven't randomized the patient early enough to be able to order the regimen. So it could be that they want this patient to start the clinical trials chemotherapy on, let's say, Tuesday. Today's Friday, and they still haven't randomized the patient, meaning they still don't know which regimen they're going to order on that patient. So if they can't order the regimen, they can't send a request to scheduling to book that appointment for that chemo. So what we've created is kind of a dummy order and a dummy appointment type to manage that. They do this today in some way in case. They kind of save space in the schedule waiting for that patient to know what regimen they're going to be on. So we needed to find a way to do that. So what we did was, we created a dummy scheduling order and appointment to hold space for that patient in the schedule. So we created an order called the Infusion Chemotherapy Research Block Appointment. And we created an appointment called the Onc Chemo Research Block Appointment so that it's clear what this is for. So the workflow is that the physician does not yet know what true regimen the patient is going to be on. So they place this Infusion Chemotherapy Research Block Appointment order. It drops a request for this research block appointment type on the clinical trials request list. The clerk treats it like a normal chemotherapy request. They assign a booking date and they put it on the regular chemotherapy request list. Now, it may even go as far as that might get put through Chemo SmartBook and actually booked an appointment in scheduling appointment book as this dummy appointment. And I've built the appointment so that it's an entirely different color from other appointments. So they know that it's a dummy appointment. So it's literally just to hold space. The physician indicates in the order the longest possible time that that patient might need in the chair. So the physician knows that the patient might go on regimen A or B, and so he takes the longest duration from those two appointments and assigns that to the block appointment. So we should have blocked enough space in the schedule to allow for that appointment to happen. Now, at some point before that actual appointment happens, because the appointment doesn't mean anything, right? It's just blocking time. Before that actual appointment, the true regimen is ordered. So at some point, the physician then knows which regimen the patient is going to be assigned to, and then they should order that correct regimen. So they'll order regimen A, and then that appointment request will be received, and it will replace the dummy appointment at whatever place in the process that appointment is in. So if it's still a request, the clerk would cancel the dummy appointment request and just keep the real appointment request. If it's already a booked appointment, the clerk will cancel the dummy appointment and then we'll take the real appointment request and book it in there instead. Now the idea is that when the physician orders the true regimen, they will put a special instruction in that scheduling order indicating that it is to replace the dummy appointment. Does that make sense? It's a bit of a mess. It's in the workflow here. If we look at the research appointments, it's in here. This workflow talks about both the electronic and the paper. I know it's teeny tiny, trust me, it does say these things. It talks about the electronic workflow and the paper workflow, and then it talks over here about the dummy appointment request and replacing it as well. So it's all included within the workflow here. The last thing to talk about are CAP appointments. So CAP appointments, so CAP stands for the Compassionate Access Program. So these are patients who maybe aren't doing well on standard of care regimens. So standard of care being this is what we would normally prescribe for this type of cancer in these types of situations. Perhaps the patient isn't doing very well. And so the physician applies for a CAP program, meaning that they want to prescribe a different drug, a drug that's not normally used in these circumstances, perhaps a regimen that's not used in these circumstances, and is asking special permission from the board to be able to go off script and use these unusual drugs for this particular scenario. Now, this is different than clinical trials in that these are approved medications, and they are probably approved for this type of care. It's just outside of the standard of care. And so the physician has to apply to this particular program in order to use this drug in this particular way. So how is CAP scheduling different than other systemic therapy scheduling? It's not any different. The orders still come from a regimen. It's still the same order. It's still the same appointment type. It comes across the scheduling. It's managed in exactly the same way. The difference comes in whether the CAP protocol is approved or not. Now, actually, this sentence isn't true any longer. Previously, the clerks had to wait for the CAP, for the physician to receive approval to use that drug before they could book the appointment. Now, with the way that the physician workflow happens, the physician cannot order the regimen until they have received approval. So if we get a CAP request from the power chart side, we assume that it is approved. That's the workflow they are supposed to use. So the only, sorry for all the scrolling. The only difference then is how the request looks in scheduling. Like I said, it uses the same scheduling order. It uses the same scheduling appointment. The only difference is the way the tumor group looks. So in, for example, breast protocols, they all start with BR. Lymphoma protocols all start with LY. CAP protocols all start with U. So this would be an example here. This would be a breast protocol that is a CAP program because it starts with U, and it's also suffixed with CAP as well. So I put CAP appointments in the PowerPoint, and I talked about it in the design and validation sessions. And it was through those design and validation sessions that we realized that the CAP appointments really aren't that different at all. But I still had called them out because they do look just a tiny bit different. But like I said, they are treated the same way as every other. There is a workflow for it. Really, it's the workflow is the same as any other. Do I still have it? Maybe I removed it. It looks like I removed it because they are no different. Yeah. Good. One less thing to worry about. Pending appointments. So we talked about, I don't think we have talked about pending appointments yet. There may be times where a physician has a patient in front of them and they want to order a particular regimen, but they need to wait for something else to happen. Maybe some lab tests, maybe some imaging, something needs to happen. Now, we would hope that they would wait for those activities to happen and then they would order the regimen and we could book the chemo. But probably what's going to happen is they are going to do it all at once while the patient's in the office with them, right? They're going to order the MRI, they're going to order the regimen, but the regimen, the chemotherapy appointment shouldn't really happen until that imaging is back and the physician has seen it. So there may be times when we need to hold off on booking that chemotherapy appointment. Now, hopefully, the physician has put that information in the special instructions. Otherwise, how would the clerk even know that they're not supposed to book it? But that's their workflow. If we get a request that needs to wait on something else, we can use the pending appointments workflow. Now, this is enterprise workflow for scheduling. I don't think it's any different for oncology than it is for any other place. And really, we just put the appointment on the pending appointments request list and hold it there until that activity that it's waiting for is completed. And then the clerk would move it back to the regular request list and move it through the regular workflow. Now, do I really think that chemotherapy is going to use the pending workflow? I actually don't think they will. I think probably what they would do is they would leave that request on the regular request list. They would not give it a booking date. They would probably mark it as waitlist yes and put a scheduling comment in saying what they're waiting for. In talking to the chemo clerk and the managers there, I get the impression that they kind of want everything on one list and they just want to be able to manage it and see it all together to remind themselves that it's there. So the pending appointments is part of the official workflow. It's something that we teach. It's something that I support when I'm speaking with them. But I can see them not using it, and it doesn't bother me that they would not use it. I think that what they're suggesting would work just as well for them as well. Okay, so if we look at the workflow, it's split up into tabs that represent the stages of work that the chemotherapy clerk runs through as they are booking. So there are a number of stages. So new requests that come in, how are we going to deal with new requests as they drop on the request list? Pre-optimization, how do they get that list ready for optimization in Chemo SmartBook? Then there's the Chemo SmartBook extract. There's the actual work in Chemo SmartBook. And then there's the scheduling of the appointment after Chemo SmartBook, so putting them actually into the schedule. And then managing that schedule after it's been optimized and scheduled, but before the appointment. So there's some time between when it's scheduled and when it's booked, so when it happens, where things might change and how will they manage those. The rest of the document contains what I termed adjunct workflows. So they are little pieces of workflows that fit within all of these larger sections. So they are more detailed about how to do a specific function, such as how to document the ready to treat date, how to manage research appointments, how is the dual modality different, how to update the chair and nurse time. So these are workflows that really are like how-tos kind of, but I wanted to be able to point to them when I'm teaching or when I'm supporting, to be able to say, oh yeah, remember this is how you update the chair and nurse time. So there's something to come back to all the time as to how that actually works. So we've already talked about new requests and when they come in. So if we look at the request list here, oh, that's the lab. We look at the systemic therapy future request list at the BCCVA chemo location. You can see all the requests that are on the request list, and I would expect this to be hundreds and hundreds and hundreds and hundreds of patients long. If we think that they do 85 patients a day, they probably get 100 or more requests a day to manage. They book 8 days out, but they soft book as far out as they need to. So I would expect that they would have a month at least worth of requests kind of sitting out here waiting to be booked. So it will be quite a lengthy list. The request list always sorts with the newest items at the bottom. So we would expect the items at the top to all have a BCC chemo booking date. So the clerks, the initial clerk, so it's kind of a two-stage process. The initial clerks will be looking at the request to assign a BCC chemo booking date, and then what they call the chemo clerk will actually take those requests from specific booking dates, run them through Chemo SmartBook, and actually book the appointments. So it's kind of a two-clerk process. Whether or not it will actually be two people or whether it will be more people, it's a two-clerk role process, let's say. Down at the very bottom, what was yours called, Anoop? Scheduling? Who's this?
I just sorted them by last names. They're all scheduling, last name scheduling. Go for Cora or scheduling.
Oh, here we go. Scheduling demos, scheduling Suzanne, Cora, Violet, Miranda. Okay.
Yeah. Go for a scheduling demo because that's my dummy patient to test on everything.
Okay.
Any of them will do. I don't care, but yeah.
Okay, I'm just going to move I just want to make sure that we follow the workflow. I can't show you guys both screens at once. So the workflow says to review the future request list for appointment requests with no BCC chemo onc booking date assigned. So that would mean we would look down at the bottom. We would find the request that we want to work on. The next step is to review the special instructions and scheduling comments fields for further information. So the request list contains a lot of information about the request itself. It tells us what protocol this came from. So it's a breast protocol. This is cycle 1. So this is a new patient, and it's day 1 of that cycle. So cycle 1, day 1 is like the ultimate newbie patient, hasn't seen any chemotherapy before. So now we automatically know that we have to assign a BCC booking date. We have to document the ready to treat date. And we know that we don't have to follow any ongoing treatment schedule. So this patient hasn't had any chemotherapy, so we have a little bit of time to get them within the schedule, right? I think that the provincial guidelines are 14 days. BC Cancer Vancouver is actually working more like 21 days. So we know we have some time that we can use. So over here, we're looking for the special instructions. It says for cycle 1, we know this is cycle 1, the chair time should be 140 minutes and the nurse time should be 80 minutes. So we'll have to make sure that that is true. See if there's anything else. It's not a dual modality patient. It's not a research study patient. And then I have these fields over here just for my purposes. Of course, the fields are, I think that we push out a certain configuration of fields and columns in here, but it's configurable per user. So each user can determine which columns are most useful for the work that they do. I have my own preferences and that I suggest to the chemo clerks. But of course, if they find that a different configuration works for them, then that's what they can work with. One thing I hate about the request list is every time you do anything, it here we go, Suzanne. So the first thing was we were going to look at that special instruction and assign the chair and nurse time. So if we go right click and we modify, it's important to go to modify and not modify request because we actually want to get to the order. Here's the order here. So the special instruction says if this is cycle 1 and it is cycle 1, then the chair time should be 140 minutes. So we'll change it to 140 minutes. And the nurse time should be 80 minutes. So we'll change it to 80 minutes. Remember, I said also that as part of that, I would go into the scheduling comments and indicate that I had made those changes. And then it resets it and I have to find it again. I would probably look up the patient by the patient name so that it wasn't so onerous. Why don't we do that? If I was working on a particular person. Here we go. Now I don't have to scroll as much. I know I'm just dealing with this one particular request anyway. So the next piece in the puzzle is the appointment request a cycle 1 day 1? This one is a cycle 1 day 1. So we need to create that pre-recurring encounter and document the ready to treat date. And as I said, in the workflow, there is a tab specifically for that workflow. So we could go to the adjunct workflow for ready to treat date, and we could look at that workflow to manage that. Actually, I can show you here. So we're here is the appointment request, a cycle 1 day 1 request, create the pre-recurring encounter, and then there's a link to the RTT date workflow. So it would bring that up for us so that we could follow that.
So Julian, can I interrupt for a minute? Sorry. So you always update the nurse time and all that, then you go create the pre-encounter.
It doesn't really matter which way you do it.
Because the way I read it, I wrote it the other way because I actually wrote this section of it already, but I'll go change everything because just the way because I was trying to read the workflow at the same time. So I actually did it the other way around. But do you find it, what's the best practice?
You know what? They're so unrelated to each other, it doesn't matter.
Okay.
They don't even flow to one another. It's terrible.
No, but I just thought maybe you might have it like a best practice we're supposed to teach.
So to create the pre-recurring encounter, we select the encounter and we go to person management. We want to add an encounter. We need to remember the requested date and time for this request. Remember that the ready to treat date is the same as the requested date on the cycle 1 day 1 request. So the 18th of February. We're going to pre-register an outpatient. Going to be a pre-recurring encounter for medical oncology. at the BCCVA chemo location. And then whoever the attending provider is. Just still trying to get my head wrapped around which provider is which. So then we go to the ready to treat date, and we enter the ready to treat date as the date that was on that request, which was the 18th of February.
Don't click complete yet, because I want to take screenshots, please.
Okay, yes, of course. So let me know when you're ready.
Okay. Can you give me a favor? Can you just go back to the first screen where it says the encounter information, and I'll just take a screenshot for that too. You got to put the estimated rod. Yeah.
Yeah.
Okay. Thank you.
Yeah, this is the one caveat to creating the encounter before you create the appointment, because it's still a request. It doesn't have a date yet. If it was a booked appointment, as in our enterprise workflow, this field would already be filled in. Because we don't have a date yet, I just put today and now. Now I do need to look that up a little bit more because I'm a little bit worried.
Is it ready for treatment date?
It's the estimated arrival date of the encounter, because it's a pre-recurring encounter. They want to know when you think the patient will arrive. So if you've already booked an appointment, it will just input that appointment in there, right? So it would say March 1st or March 2nd, but we don't have a date yet. We haven't even assigned a booking date yet.
Yeah.
So I don't know, maybe the workflow would be better if we did this after we assigned the booking date, because then at least we would have some idea of when it would be. Right now, I haven't even looked forward to see when it is. So I'm going to make a note that maybe I might change the workflow to look at the ready to treat date after we've looked at the booking date.
You know what Jillian and I did, and I made this stuff up, okay? So I'm not the expert, but this is what when I was writing it, what was kind of logical. So I did that first, like I assigned that ready to treatment, then I did, then I added this encounter. I actually put down ready to treat date or whatever I put it, because for the ready for treatment date, shouldn't that be, you should be trying to find the booking date on that plus or minus plus 14 days, right?
Yeah. Yeah, but it could be up to 3 weeks, right? So the ready to treat date is 18th of February, but we might not actually book this patient until the 7th of March. My concern is that the pre-recurring encounters, I think that they show up on I'm trying to think of the word, expired list in PM office at a certain point. I think it might be 30 days after it's created. I can't remember.
It's 120 days.
Oh, is it?
Okay, then there's lots of time. Yeah. Today and now is going to work. I just didn't want today and now for it to expire too soon, but if it's 120 days, it's not going to expire.
And it's only a warning list anyway. It's not nothing.
Okay.
There's no ops job to
throw
them out.
Yeah.
Okay, good.
Then you have to manually go and discharge the encounters.
Okay.
It doesn't automatically does that.
Okay. So the next step in the ready to treat date workflow is to then attach that encounter to the request. So we'll go into the request and we'll set encounter. Then we'll find that encounter for that patient that we just created. Hopefully real patients don't have so many encounters. Pre-recurring, do we see it? Is it this one? No.
It's pre-recurring.
Yeah.
It's the next one down. Go a couple more. I see it right there.
There. Okay, thank you.
Sorry, I use these patients for everything.
And that just associates that encounter to that request in the scheduling side. And it's a cue to us that we have booked we documented the ready to treat date. Now there is another safety net about the ready to treat date that I don't 100% know very much about, but apparently there's some work list or report that is going to run that will show all of the oncology encounters that do not have a ready to treat date assigned, because it is important that that get documented. You can see that it would be easy to forget that step. So there is this report that runs that would alert people to know that that ready to treat date hadn't been documented. And then we can go back into PM office and do that retrospectively. So there's no harm done, but it's good to have that safety net in place. But that safety net isn't part of scheduling, so it's not something that I train or speak to normally.
Yeah, I was told by Sam that yesterday too, because I think I have to do a help topic on ready to treat date. So there is a report that's going to be run in case they forget.
So the next step in the workflow asks, does the appointment request need to be hard booked or scheduled to a specific day or time? Now, most of the time, 98% of the time, that is not the case. They don't book the appointments here specifically to a nurse and chair and a day at this point in time. But if they had to, if the physician said this patient must start on Tuesday, then you could actually go forward and complete this request and book the appointment on that day and time as you would normally. Most often that will not be the case though. Most often we're going to go through the booking date process. So the next step is to assign a BCC chemo booking date to the request. Now here's where we probably need to go back to the regular request list here. Find our request. So now what we need to do is we know that the requested date for this patient is the 18th of February. So now what we need to do is look through the booking dates to see when the next booking date is available. Now, here's where things get a little tricky. I think if we go back here, sorry. Here. Because of the way Chemo SmartBook works, they run Chemo SmartBook 8 days before the appointments they're going to book. So if today is the 19th of February, I always hate it when it's not a very good example. The 19th of February, they're actually running Chemo SmartBook for requests that are 8 days from now. So that's where this booking matrix comes in. So it says if today is the 19th of February, Chemo SmartBook is running on, let's just fib and say the 1st of March. Chemo SmartBook is running on the 1st of March. So the earliest BCC chemo booking date we can apply is March 2nd. That's what this line here would say in real life. If today is the 19th of February, Chemo SmartBook is running on March 1st. So we can only book as early as March 2nd. So then we would know that we can't look at any date prior to March 2nd because those are already filled, optimized, and scheduled. So we can look at all the request lists that are March 2nd forward. So we would look at March 2nd to see if March 2nd is full. Today it's not, but in real life it probably would be. Then we would look at March 3rd. We would look at March 4th. We would continue on until we find a booking date day that meets our requirements, that has room in it for our patient. Now, remember, there are a number of requirements. Is the patient an ongoing patient? So do they have to be done, right around that date? Is the patient more urgent? Do they have a reserved capacity slot? Can we put them on the wait list? So all of those things come into factor as to determining what the wait list or what the date might be. Once we've found a date, so let's say that March 5th has room in it for our patient, then we know that we can assign March 5th to that patient. So then we would find our request. So I would probably have another request list open with that patient on it. Why don't we just do that? I would actually have another request list open that is by patient. Oopsie. Put my name in instead of yours. Can show my name.
Just put schedule. I'll pop up. There you go.
So we know that we're going to assign a booking date to this patient of March 5th. So we would put a March 5th date here.
Okay, Jillian, I'm going to take a screenshot, okay?
Mm-hmm.
Thank you.
So if we went through a bunch of days, March 5th, March 6th, March 7th, March 8th, March 9th, let's say we went through like 2 weeks worth and we could not find space for that new patient because this is a new patient, we have some time, we don't have to fit it into an exact slot. If we can't find an open booking date, then what we could do is we would just leave the date empty and we would put them on the wait list. So this is what BC Cancer Vancouver refers to as their new patient wait list. Patients that don't have a booking date, but they are marked as waitlist yes. So they are waiting for an open slot. They know that they don't have any space in the next 2 weeks for this new patient, so they hold them on the wait list, waiting for a slot to open. And oftentimes, most oftentimes, slots open up. Patients cancel all the time for a variety of reasons, or they get moved. Maybe they drop regimens, they can't make appointments. So when that happens, the clerks see that there's an open spot. They will find the next appropriate patient on the new patient wait list, those that don't have a booking date, and they would book that patient into that slot. Let's continue on with our example of it being March 5th. The next question on the workflow is the request part of a multi-day cycle? Oopsie, that's you guys. I meant to pull over the workflow, sorry. So we're over here. Is the request part of a multi-day cycle? Remember that some cycles have day 1, day 8, day 15. So if that's the case, then what we would do is we would look for the other requests that belong to that cycle, and we would mark them all with a scheduling comment of multi-day cycle. Now, what that means is that the other days, day 8 and day 15, would not be giving a booking date yet. They would remain on the request list without a booking date, but the scheduling comment indicating that it's multi-day means that we're waiting for day 1 to be booked. Now, we've given day 1 a booking date, but we haven't actually booked it. And as we've just talked about, things can change rather rapidly. And so that booking date of March 5th might actually change before the appointment gets booked for March 5th. So if that happens, what we need to be sure that we go back to those other requests and update those as well. That's why we don't book the second and third day right away, so that we don't have to reschedule 3 appointments in the event that things change. We only have to reschedule the 1 appointment. As soon as the 1 appointment actually gets booked in the schedule, then we would go back to the day 8 and day 15 requests and assign those booking dates accordingly. So if it ends up that this request does get booked on March 5th, then we would assign booking dates for the 2nd and 3rd request accordingly. If this request gets changed to March 10th, then we can assign booking dates accordingly. Does that make sense?
Yes. That does. Can I ask you another question, Jillian? Mm-hmm. Go back to where is that just that matrix you have, right? So you said it goes it comes from Chemo Smart Book. Do they have it open somewhere? Like, is it a separate application a Cerner downloads into? Like, where?
It is. Yeah, we'll get to it in just a minute.
Okay, perfect.
Okay. So does the request qualify for a reserved capacity slot? In our example, it doesn't, but does it qualify for those special liver slots or those clinical trial slots? Or does the request need to go on a wait list for a particular day? So if we didn't find any space within the 2 weeks that we needed, would it go on a wait list instead? So this workflow encompasses everything that could happen to any new request that falls on the request list. So the clerk asks all of these questions and follows all of these potential workflow options in order to get a request on the request list with a booking date, which is the end result, right? That's the end, what we want. So here we have our scheduling, Suzanne. Where is she? Suzanne. Here she is, and she has a booking date of March 5th. So that clerk role has completed their role now. They've found the new request, they've gone through all of the workflow, and they've assigned it a BCC chemo booking date. So this first tab of the workflow is now complete. You guys think we could just take a 2-minute break and then come back?
Okay.
Okay.
Sounds good. Thank you.
Okay. See you in a minute. All right, are you guys there?
Yep. Yep, I'm here.
Okay. Okay, so that was the new request workflow. So that's kind of what the ECU clerks do today, or what the new clerk role up in chemo will do, that kind of first pass at all the requests to assign them a booking date or soft book them, as they refer to it. So the next step is for what they call the chemo booking clerk to take care of. So I called it the pre-optimization stage, where they look at a list of requests that are going to be put through Chemo SmartBook ready for scheduling, and they ensure that everything is correct on that list. So it typically occurs 1 day prior to the extract generation in Cerner. We'll talk about the extract in Chemo SmartBook right after this. So the first thing that the clerk does is they use that same request inquiry that we've been using, and they look at the booking date that they are going to optimize. So on our example here, I happen to have some requests here for November 2nd. So let's pretend this is March 2nd. So the clerk wants to optimize all the appointments that are going to happen on March 2nd. That should be about 8 days out from today normally. So she filters the list for the day that she's going to optimize or wants to schedule, and she looks at all the requests that are on it. Now remember, we probably have around 90 requests, maybe 95 requests. We have room to book 85 patients. We have 85 chairs that we can book, or 85 spaces available that we can book for that particular day. But remember, we'll have patients that have assigned a BCC chemo booking date, but that are also on the wait list. So these are patients that we know this day is full of patients, but we're hoping that this patient can be done on this day anyway, that maybe there have been some cancellations, or maybe this patient can be considered urgent enough for this to happen. If we look at the workflow, it's basically an iterative workflow that looks at the list and at the patients on the list and prioritizes patients over other patients based on parameters that they use today. So this step here says that we'll review the list. Are the requests with the requested date greater than the BCC chemo booking date? If we look at the requests, and I'm not sure today there are any, there aren't. Remember that requests remain on the request list, and then if the order is changed in PowerChart, the requested date will update on the request. It doesn't send any alert to the clerk or scheduling to let them know that that has happened. It just automatically updates the request. Because it's only a request so far, scheduling knows it can just update the request. So let's take this example. So its requested date is November 1st, and so we assigned it a BCC chemo booking date of November 2nd. So it's pretty close to when they wanted to have it requested. But what if between the time the order was originally placed, maybe last week or the week before, the requested date was November 1st, what if the physician went in and decided, oh no, we're not going to do that on November 1st, we're actually going to do it on November 10th. And so they changed the date in the PowerChart side to November 10th. That means this request would automatically update to a requested date of November 10th. And now we see we have a disparity in that the requested date is November 10th, but we've said that we're going to book it on November 2nd. Well, we can't book it on November 2nd if the physician doesn't want it done until the 10th. So we know that we have something that has changed. So what we can do then is we would change this booking date from November 2nd, and we would look through that process that we went through before. We would look through to see what dates near November 10th might have room available, and then we would book this to that particular date. Let's say that there was room on November 11th. As soon as we assign this a booking date of November 11th, it is removed from this list because we're filtering this list looking only for booking dates of November 2nd. So that takes care of this part of the workflow. Because the requested date had been changed and it had eclipsed the booking date that we had assigned, then we would assign it a new BCC chemo booking date. Now, in the workflow here, we say that it's going to happen 1 day before optimization. In actuality, I see this as an ongoing process of reviewing the request list to make sure that the requested dates haven't eclipsed the booking dates so that they can remediate that as soon as possible. But it would get caught here if it hadn't gotten caught anywhere else along the way. The next step says to identify patient preferences and same-day appointments and indicate in the scheduling comments. So this talks about if in the special instructions, perhaps the physician had said that the patient likes to be booked in the mornings because the ferry from wherever they're coming from, Bowen Island, doesn't run in the afternoon, or whatever reason they need to be booked in the morning. They can add that in the scheduling comments. And they would look for any other same-day appointments. So they would look to see if the patient has any RT treatments that day. Maybe they're going to MDC for something. Maybe they have some other appointment. And so then they can place in the scheduling comments any restrictions around that. So if the patient had a blood transfusion in the morning, they could put that in the scheduling comments, indicating that this patient should only be booked in the afternoon. These scheduling comments go across to Chemo SmartBook, and so then they can be considered during that optimization phase. So the patient then wouldn't be booked in the morning, they would only be available in the afternoon. The next thing that the clerk would look for is if there are any BCC chemo waitlist appointment requests. So are there any requests on this booking date that are on the wait list? So these are patients that perhaps there wasn't room for them when the clerk was assigning a booking date, but she really wanted it to be done on this date, so she assigned the November 2nd date and indicated that it was a wait list. The workflow says if there are no wait list appointments, then we're done. If there are wait list appointments, then we need to manage them. We can't, we technically can, but we should try to remove as many waitlist patients as possible and make sure that we are only have as many patients as we have spots for. So the next thing to ask is there room in the BCC chemo booking date to remove requests from the waitlist? So have there been any cancellations? Are all the reserved capacity slots assigned? So then the clerk would look at this request list and determine whether or not there actually is space. So down at the bottom here, it tells you how many items are on the list. This one only has 18 today. But what if it started with 90 patients on this list and 5 of them were wait lists? And then by the time the clerk got to this step in the process, there were only 80 requests on the list. What happened to the other 15? Well, probably they got canceled or they got moved or something else happened. But now there is room. And so if there is room on the list, then what we can do is we can remove the wait list flag, as I call it, on this particular request. And we could say that it's no, or we could say that it's none, so that we have a request list that doesn't have any wait lists on it. Now, it could be that it's not as simple as that. It could be that we come in here and we still have 95 requests on this list and 5 of them are still waitlist equals yes. We haven't had any cancellations and there's no room on that day. So then the process is, and I think it's in the workflow. Yes, so if there is room, as we just saw that there had been some cancellations, then you can remove the waitlist indicator and just make it a regular request. If there's no room still, as like we were just talking about, perhaps there's still 95 requests on that list, then we talk about, is it possible to reassign any of the requests to a different BCC chemo date based on protocol allowances? And we talked about this the other day, that min-max that protocols are allowed. The clerks have a process of knowing which protocols have which min-max values on them. So they might know that this breast protocol has a min-max of 2 days, let's say. So that means that it can be done plus or minus 2 days from its requested date. So they can look either side of that to see if they can move it. So if they can move that patient, then they would assign it a booking date that is a different date. So that would remove that patient from the list. So they go through and they look through all of the patients to make that determination. They can also use the priority, of course. If they have patients that are of less priority than others, they can move those to a different date. So this is all within the clerk's realm of responsibility, within their scope of practice. I don't think that's the right term, but they're allowed to make these decisions and make these changes based on what they see on their request list. However, if they still, at the end of that process, have too many patients on that list with too many waitlist patients, then it becomes a clinical determination as to which patients stay and which patients don't. So then they bring in the clinical nurse leader and the provider, and they review requests to determine which patients could possibly be moved a day or two based on clinical determination. So how is the patient doing? What protocol are they on? Those types of things. So then they would move patients to a different booking date based on those determinations. So those clinicians would let the clerk know which patients can be moved by how much. And then at the end of that, if they still have too many patients on the list and they have waitlist equals yes patients, they will sometimes, not unoften, send all of those requests through to Chemo SmartBook. The waitlist patients will not be optimized. They will remain on the request list even after all of the other requests have been booked. They would still have the booking date of November 2nd. They would still be waitlist yes. But remember, we're still 8 days out, so things can still change. So the clinicians are hopeful that something will happen within those days where the other patients maybe would cancel or couldn't make their appointments, and they could do these waitlist patients. At the very end of the day, if the day comes, if November 2nd comes, and they still don't have any room, they often will bring the patient in anyway, and they will try to find room for that patient because it's gone through that iterative process of, clerical determination, can they move the patient, and clinical determination. And if the clinicians determine that the patient really should be treated on that day, then they will do their very best to make sure that patient gets treatment on that day. So this iterative cycle continues and continues until they have a request list for that particular booking date that they are ready to book. Now, in normal circumstances, in other clinics, we would just right-click, complete each request, and find space for them in the schedule. But like I said, we use this third-party application called Chemo SmartBook that helps optimize these requests. You can imagine if there are 85 patients on this list, we have, I can't remember how many chairs are in chemotherapy. It's impossible for a human to put them all in any kind of optimized way. Remember that each appointment has a different duration. They're not like other clinic appointments where every appointment is an hour or 2 hours or even 5 hours. Each one is different. This one might be 45 minutes. This one might be 3 hours. This one might be 9 hours. And so there is a program that they are using to help them look at all of the requests that they have that they want to book on November 2nd, and will plinkle them through their algorithms, do their magic and their voodoo, and come up with a suggested schedule at the end. So let's talk a little bit about Chemo SmartBook and the extract. So I said Chemo SmartBook is a third-party application. It's a web-based application, and it's run through the IMETS program. I think it's the IMETS program that developed the application and are responsible for it. I don't know how it works. I have seen it. I'm actually going on Tuesday to work with the clerk at BC Cancer Vancouver to see a little bit more of it. But it's not our responsibility to know how it works or to support it in any way, or teach it in any way, shape, or fashion. It's kind of a black box. We send information to it. It sends information out that we use, and that's the extent of our relationship with it. We have tested with it. We work closely with the team. But I just want to make sure that we all understand that there is a line between CST and what we're doing and Chemo SmartBook and what they do, just so we don't mix too much or get our responsibilities mixed up. So this is how I represent Chemo SmartBook in a workflow document. Cerner sends an extract of information to a file. So every night a extract runs. We'll talk about the qualifications of that in a minute. Every night an extract runs and drops the information about all of the appointments and requests in Cerner into a file folder. I don't know where, in some magical place. I really don't know where it goes. it's run by an ops job, so we can run the extract manually, but it's actually usually run automatically by an ops job, and it runs in the nighttime and drops this file for Chemo SmartBook in the middle of the night. Then the workflow is that within Chemo SmartBook, so the clerk logs into the Chemo SmartBook application and can find that file through that application, which pulls all of the Cerner information into the Chemo SmartBook black box, where they do the optimization in there. Now I know the clerk does some manipulations within there. So Chemo SmartBook knows how many chairs are available on a day. It knows how many nurses are available on a day. It knows what the schedules are of each of those resources, when those resources are available, when they're on lunch, when they're not on lunch. It knows the pharmacy mixing times for each type of drug that might be ordered. The extract sends it all of the appointment information. So the extract sends it the patient's name, what protocol the patient's on, how long the patient should be with the nurse, how long the patient should be in the chair, that type of information. So Chemo SmartBook takes all that information, what protocol the patient is on, what drugs are in that protocol, how long pharmacy needs to take with that drug, which nurse is available, which chair is available, where they all live, and it optimizes all of those patients together into a schedule. And it spits out export document. So it's an Excel file document that it produces. I want to be clear, there's no integration between scheduling and Chemo SmartBook. They do not talk to each other in any way, shape, or form. They don't know each other exists. This extract is a file that we drop for Chemo SmartBook, and this export is a file that it drops for the clerk. So there's no talking back and forth. It doesn't book the appointments for us at all.
So that's good, Jillian. Thank you for that clarification. So the clerk just looks at the Excel. They're used to looking, then they book the appointment. They have to look at that Excel spreadsheet to get the times and stuff.
Exactly, they do that today. Exactly.
Yeah, so it's like they already know that part, so we can say as established procedures. I can put some of that in that. So that's, thank you so much. Yeah, because that's the part I was actually getting mixed up with when I was doing it last night. Thanks.
So let's talk a little bit about this extract piece. So we've talked a lot about that regular chemo request list, that Onc Systemic Therapy Future request list, and how the requests have to be on that list. When we talked about the research requests, how they fall on that research request list, and then the clerk has to put them on the regular chemo request list. And this extract is what drives all of that, why that has to happen. The extract pulls from that list in very particular ways. So the first step is the request must be on that request list. So let's talk about what qualifies for inclusion on the extract, and I'll update this slide as we talk. It's an old slide. So all of the Onc chemo infusion and Onc chemo treatment 2 infusion and those dummy block research appointment requests, all those scheduled appointments up to 15 days in the future qualify. So the extract looks at scheduled booked appointments as well as appointment requests. Now remember, I said that most often they don't direct book chemo appointments, but sometimes they do. So the extract needs to know about them because Chemo SmartBook needs to know about them, right? If an appointment is booked on November 2nd for 11 a.m., Chemo SmartBook needs to know about that, to know that that chair and that nurse are already busy at that time. So that's why we use the scheduled appointments. Up to 15 days in the future talks about how we actually send Chemo SmartBook more information than it needs for a particular day. So although we might be optimizing November 2nd or March 2nd, let's say March 2nd, we'll actually send it information for the next 15 days. It has way more information than it needs. And then once Chemo SmartBook gets that information, it filters it down to look to only the November 2nd days. It also looks, so the extract also looks at all of those same appointment types as requests on that future request list. Again, up to 15 days in the future. It actually looks at the booking date, and it only sends requests that have a booking date, and that booking date has to be up to 15 days in the future. So you can see that the extract then looks at all scheduled and soft booked appointments from today up to 15 days in the future. And it sends all of that information onto that file folder that Chemo SmartBook can access. What doesn't qualify? No other appointment types qualify other than those three: the Onc Chemo Infusion, the Onc Chemo Treatment 2 Infusion, and the Onc Chemo Research Block appointment type. Those are the only three that qualify. Nothing else qualifies. No follow-ups, no blood transfusions, nothing else. Those are the only three. Canceled appointments don't qualify. So if an appointment is booked for next week, it would normally qualify for the extract, but if it's a canceled appointment, it does not qualify. On hold appointments don't qualify. So if an appointment is placed on hold for any reason, it won't qualify either. Appointments and requests that are more than 15 days in the future won't qualify. Appointments that are not on the Onc Systemic Therapy Future Request list will not qualify. And so if a request is placed on the action pending list, it won't qualify. If a request is on the reschedule list, it won't qualify. If a request is on the research request list, it won't qualify. It must be of one of those three appointment types. It must be scheduled or be a request up to 15 days in the future. It must have a booking date, and it must be on this request list in order to qualify. Now, during regular working, this isn't something that we need to worry about. We're not running the extract manually, so we don't need to worry about, oh, is that going to qualify or not qualify? We should have, me and the team and the Chemo SmartBook team should have developed the extract in such a way that everything should qualify if normal workflow is followed. So these qualify or don't qualify statements really are troubleshooting statements. For me and others. So if in the future after go live, Chemo SmartBook isn't getting everything that they are expecting to get, we can use these statements to kind of understand what should or should not be on that extract. But it's not something day to day that we need to worry about. How does Chemo SmartBook get the extract? We've already talked about that. Cerner automatically creates this extract and uses an opt job to send it to a file for Chemo SmartBook every night. And then Chemo SmartBook imports that data, manages the requests, and does the optimization process. And the extract contains all the data points required for this. There's nothing else that needs to be done. As long as the regular workflow is followed, requests drop where they're supposed to, they're assigned a booking date, they should qualify as they appropriately, and then Chemo SmartBook has all of the information that it needs. I think I have an example. Looking. That's not it. Sorry, guys. I think I have. I had an example. I can't remember where I stored it. Because you can never find anything when you need it, right? Oh, I think I found it. I did. So this is a mocked up example of what the export document would look like. So it's a mocked up example of what this document looks like, what comes spitting out of Chemo SmartBook for the clerk to use. So it shows them what date and time Chemo SmartBook was run. So it was run on October 28th, means that's the day they actually performed the function within the application. And the date of the appointments that they were booking that day were November 2nd. So November 2nd was the booking date. So it's an example of the request list that we were just looking at that had a booking date of November 2nd. All of these requests were sent to Chemo SmartBook with a booking date of November 2nd. And so Chemo SmartBook has optimized them into a schedule for us. So it shows what the patient name is, what type of appointment it is, what the protocol is, what the day of treatment is, and then the information about actually booking the appointment. So this information helps the clerk find the right request on the request list, and this information tells the clerk when to book the appointment for. So BC Cancer Vancouver uses what are called pods. So they have a pod of 4 chairs and one nurse in that pod. So pod 1 is assigned to nurse 1, and then they have a number of different chairs. So this appointment should be assigned to nurse 1 in pod 1, chair 3 at 2 o'clock. And it would be a 60-minute chair time and a 30-minute nurse time. So the request should already know should know this information, right? The request already knows that it's a 60-minute chair time and a 30-minute nurse time. The clerk is just going to tell it to go to chair 3, nurse 1 at 2 o'clock. Does that make sense? So every request, every entry in this export from Chemo SmartBook should be a request on the request list.
Yeah, that makes sense, Jillian. That's a good visual. Thank you.
So then we're on to the next step of the workflow, the actual scheduling of the appointment. So it occurs the day of optimization. So optimization referring to Chemo SmartBook. So it says that we schedule requests from the future request list to the indicated chair and nurse at the indicated time. So we right click and complete the request to do that. And we have a workflow for booking specific nurse and chair. Now remember that in our, so my favorite way of booking appointments is we would complete the request. It would enter the request into, so this happens to be a dual modality patient. Remember I said that if the dual modality flag is set, then when you try to book or change any appointment, you would get a guideline or a warning pops up. So here is an example of that happening. Tells us about the information. So here, my favorite way of booking is dragging and dropping. But when we drag and drop, when we have more than one resource, Cerner helps us by assigning the second resource automatically. So if I dragged this appointment to the pod 2 chair 3 resource here, it would assign that resource because that's where I dragged it to, but then it would look for the first available nurse. And the first available nurse is probably over here. It's probably nurse 1. But nurse 1 doesn't take care of pod 2. So what we're left with is a requirement to individually book the chair and the nurse for every appointment because we need to assign exactly what this Chemo SmartBook output told us, right? So this one told us that we're going to assign nurse 1 and that it's going to be pod 1, chair 3 that we need to book it at 2 o'clock. So in order to do that, let me find it again. We have to go to the schedule function. So it says to book it in pod 1, chair 3 at 2 o'clock. So we would put in 1400. It already knows that it's a 5-hour appointment, so we would say okay. The override wouldn't normally happen in real life. So we know that the chair is correct. It's in pod 1, chair 3, like the export requested, but we don't know that the nurse is correct. It happened to have selected the correct nurse in this example, but it could very well have not selected the right nurse. So we need to, if it did not select the right nurse, if it selected nurse 3 instead, then we would schedule nurse 3 instead. We would find the correct nurse and assign the correct time for that particular and again, the override wouldn't normally happen in real life. So that's covered in the workflow as well. There's an adjunct workflow for assigning booking specific chairs and nurses. It goes through that process of selecting the chair resource, selecting the appropriate slots, entering the appointment time, and doing the same thing for the nurse until we get. So this will become extremely common, normal practice for the clerk within the first day of using the system, but I wanted to have a workflow for it just to make sure that we understood all the steps. So then just like any other appointment, as soon as all the resources have been assigned, then we can confirm the appointment just like we would any other appointment. Sorry, trying to find back where I was. We're here at scheduling. So we would go through the export from Chemo SmartBook one by one. We would find the request, and then we would book it according to what it tells us. Now, there are a couple of caveats to this as well. Any appointments that have been hard booked already, of course, how do I describe this? So if we hard book an appointment before we optimize, so let's say today we booked an appointment for March 2nd before we've optimized for it. So we book an appointment for March 2nd at, let's say, 11 a.m. and we book it to nurse 1 and chair 1. Chemo SmartBook honors that booked appointment in that it knows that that patient needs to be booked at 11 a.m., but it may move the resource. So it may not be optimal that that appointment happen in chair 1 with nurse 1. It will happen at 11 a.m., but it might be optimal that that appointment actually happens in chair 15 with nurse 15. So we have to be careful when we're scheduling these. I think that my workflow recommends that we look for appointments that are already scheduled. So then what we would do is we would look to the date that we're actually going to schedule. I think we said we would pretend it was March 2nd. And any appointments in here that are already booked, we would find that appointment on the export and we would reschedule it to its new place. So you can imagine that maybe we had one at 8:15 and chair 1, nurse 1 here, but the Chemo SmartBook optimization said, oh yeah, well that it actually isn't optimal that that appointment happened with those resources. Let's move it over here. We'll actually do it with nurse 6 instead. So then we would be in a reschedule situation. We would reschedule that appointment. We drag it up to the WIP, move it to the resources that needs to be to be sent to instead, and then that piece would be completed. We could consider that row to be completed. We could move on to the next row. So we can imagine that at the end of the document here, when we've actually booked the 34th patient, our request list that we filtered to November 2nd should be empty. We should have booked every appointment on that list unless one of them had a wait list entry. That appointment would stay on the list because it would not have been optimized. It does not get to have a day and time just quite yet. We talked about that earlier, how they might keep it on the wait list and try to fit it in up until the last minute.
So we could also use the shuffle function for that, right? Just moving it from one nurse to the other.
I don't think you can because of I think I've looked at using the shuffle function because there's 2 sets of resources and both have to specifically be assigned. I don't think you can shuffle.
Good to know. Thank you.
Look, I have a workflow for that. Cerner Shuffle functionality will not work with systemic therapy appointments. It does not allow for specific scheduling of secondary resources. So we actually use a modified reschedule function instead. So that does sometimes happen, Anouk. So even after all the appointments are booked, we'll get to the next step in a minute, even after all the appointments are booked, what happens is, so you can see that on the Chemo SmartBook extract, there's also a tab for nurse schedule. This comes from Chemo SmartBook. So it is a visual representation of each of the nurses that are in this list here. So it knows that nurse 4 is going to be 60 minutes in chair, by chair 2 at 10:15. And so it's a visual representation of the nurse's load their workload for that particular day. And it's the clinical nurse leader who looks at this, this list or this visual representation every day and helps to determine if this is appropriate workload. So Chemo SmartBook is smart enough to know about, like, algorithmically, are all the appointments optimized as far as pharmacy nurse mixing time, you know, that nurse went on lunch and that chair is empty. Like, it knows all of those factors, but what it doesn't know are the human factors, right? Did somebody call in sick this day? Does Nurse Sally not like to do that particular protocol? Is she not qualified to do that particular protocol? So then after everything is already booked, then the clinical nurse leader looks at the workload. Actually, I think she does it just before, but she does it iteratively throughout the process. We'll look at the workload for each nurse and may ask patients to be shuffled around. So the clinical nurse leader might say, Sandra, can you please move test patient 16 and switch them with test patient 61? And so normally that would be a shuffle. That would be easy to do in a shuffle situation, but we can't do that. So we actually reschedule each of them to get them into the slots. So that covers up to scheduling. So this is the scheduling. So after the appointments have all been scheduled, then the clerk calls the patient to let them know about their appointment. They don't call the patient before this point in time. They used to call them when they gave them a booking date, but those dates can change so frequently that they haven't found that to be useful. So it's not until they've actually done the Chemo SmartBook optimization and they've scheduled them in Cerner properly that they actually call the patient and let them know about that appointment. So this happens 8 days before the actual appointments are going to occur. So we've optimized today for March 2nd, but we've done this, I don't know, let's say we do it today, February 19th. So there are, you know, there's a lot of time between now and March 2nd, there's normally 8 days. So there's 8 days between when an appointment is booked and a patient is called about that appointment and when that appointment will actually happen. A lot can happen in 8 days in chemotherapy world. So we have a workflow that is I call 1 day prior. So again, it's about the clerks and the clinical nurse leaders looking through the schedule to make sure that everything's in place for the next day. So this would happen on March 1st to make sure that everything is as it should be before the next day. So they review the request list. They look to see if there are any requests for the next day that are on the wait list for that particular day. So remember, I said that all of these would be booked, except perhaps maybe this one that has a wait list yes designation. So none of these would be here. They would all be booked. But on this particular day, there might be one that still has a wait list designation. So the clinical nurse leader and the clerk would look through to see, is there any space in the schedule? Has there been any cancellations? So are there spots in the schedule that they could use and they can actually book that appointment into? So they would do that if they could. Are there any waitlist new patient appointment requests? So then they're looking for those new patients that they haven't yet been able to schedule. So maybe they've been on the request list for a couple of weeks. They don't have a booking date yet. So if a spot turns up for tomorrow, they could potentially book that patient in for tomorrow, and then they would call them right away and ask them if they could come in tomorrow.
So Jillian, sorry, Jillian, I just missed the first part. Who reviews the day prior? Who is the person who reviews the day prior to this?
This would be the clerk would be looking to see if there's any space, but the clerk also works very closely with the clinical nurse leader to help work that through. There's a lot of communication between the clinical nurse leader and physicians. Physicians might call and say, oh, my patient's super urgent, can you fit them in? So it's definitely a very flexible, fluid, moving situation iteratively where they're looking at lists and changing things around and moving things all the time. They do this today in case, so it doesn't concern me that they, you know, I think it's something they will uptake very quickly within Cerner. It's just a different way of looking at it, that's all.
Okay, thank you.
I think I just have one other, oh, right, the reschedule. So rescheduling booked appointments. So if today we've optimized for March 2nd, we've booked all our appointments for March 2nd, and we call the patients and we tell them, oh, your appointment's March 2nd at 9 a.m. They might come back and say, well, no, that's not going to work for me. I can't make that day. And so then we're in a reschedule position. So there's a couple of ways that reschedules might be initiated. The first is a clinician-initiated reschedule. So the clinician, the physician or the nurse might get asked by the patient to reschedule it. They actually do that within PowerChart. So they would reschedule those requests within treatment calendar, like we've talked about. And when those booked appointments get moved in treatment calendar, then a review or rescheduling request comes across for the scheduling clerk. So the scheduling clerk is going to have to make sure that they review those lists regularly. And then they decide whether or not they're going to actually just rebook that appointment or whether they want it to go through Chemo SmartBook 2 again. And that really depends on how far in the future they're going to reschedule that appointment. If it's just a day or two, then it might be okay just to hard book it. So they just straight reschedule the appointment. If it's going to be a week or two, then it probably needs to go back on the queue to be optimized through Chemo SmartBook. So then we have a process where they need to place the appointment on hold. Remember that what we need is we need a request on that request list in order for it to fall on the Chemo SmartBook extract. So our workflow involves placing the appointment on hold, updating that BC. So we've got a review request. We would assign a booking date to that review request and put that review request onto the regular chemotherapy request list so that it qualifies for the extract. We have to put the appointment on hold because we don't want it to hold that space any longer, right? So normally we would just reschedule the appointment and that would open up that space and put the appointment somewhere else in the schedule. But in this case, we're actually waiting for Chemo SmartBook to optimize it. We want to free up that space because we know the patient isn't going to be there. So we can't just leave the appointment there because another patient could be using that chair. So we place the appointment on hold so that it stays, it opens up that slot. And then we use that request to put it on the request list to go through Chemo SmartBook. Then once we book that appointment, we send it through Chemo SmartBook. It shows up on the schedule that we get from Chemo SmartBook, and then we can schedule it, and then it will, sorry, I've lost my place here. Then it will remove the on-hold appointment and it will move it to the new space. The second way that a reschedule can work, and I don't think that this will happen in the future, but currently a patient can just call the clerk and ask them to reschedule the appointment. So it's possible that a clerk could get a verbal reschedule request, and it's the same process as up above. It's just that we don't have a request for like an electronic request, so the clerk has to create it. But I think really what will happen is it will come from the clinician. I don't think that this second option will happen very often in the future. The next thing to talk about is no-show. We can't use regular no-show functionality with systemic therapy appointments because it does not preserve that scheduling order for rescheduling. So if a patient doesn't show for a chemotherapy appointment, we don't cancel the appointment. We don't cancel the day of treatment. There's a whole process around them contacting the patient, seeing if they can come in a different day, trying to determine why they didn't come, all of those pieces that happen on the patient care side. And then the clinicians determine whether or not it's actually going to move forward or not. So they will, on the PowerChart side, they will reschedule it using a treatment calendar, or they will cancel that day of treatment, which will cancel the appointments altogether. But we can't use the no-show action at all. It all has to come from PowerChart. I think we talked a little bit about parameters not met. This was the whole idea around a patient would get checked in for an appointment And then the nurse would give them an assessment and would determine that they actually cannot receive treatment that day for whatever reason. Again, similar to no-show, we don't want to cancel that appointment. We want to preserve that day of treatment. We want it to happen at a different time. So we actually just want to reschedule it. And that happens on the power chart side. The clinicians determine when the patient might be ready for treatment and sends a reschedule request through treatment calendar to the scheduling side. And then we're in a rescheduling situation just like we were before. So these are all variations of the rescheduling process. We already talked about the pending list. And so the last thing I wanted to talk about was MDC booking. So because BC Cancer Vancouver is so busy, they run over capacity so much, they've determined that there are some types of drugs that don't have to be given in the chemotherapy department. Now, the chemotherapy department consists of specially trained nurses who are trained to administer chemotherapy drugs. So most of the drugs have to be given in those areas by those nurses. But there are some drugs that are used in chemotherapy that can be administered by other nurses. They don't have to be chemo-certified nurses. And so if the chemo department is over capacity and needs to send some patients onward, they can send patients from specific protocols. They can send them to the MDC department instead to have their infusion done there. So what we've allowed is we've allowed those appointments to be booked at MDC. So that means that if you go to the MDC location in scheduling, you will find that there's an onc chemo infusion. The appointment request is valid at that location as well. Along with all their other infusions here. So it's possible to book an onc chemo infusion at the MDC department. So it's not automatic. The chemo infusion requests never go to the MDC request list. They always fall to the regular request list at the chemo location. And then it's the clinical nurse leader and the manager and the clerks who determine which patients might be done at the MDC instead. And so this workflow allows the request to be done at the MDC location. So it's as simple as you just take the request and you complete the request. There's another dual modality patient. So all of the appointment information remains the same. The durations are the same. All of the drugs are the same. Everything's exactly the same, except instead of sending it to the VA chemo, what we're going to do is we're going to change the location to the BCC VA MDC location. Everything else remains the same. So when we click move, it updates the work in progress window and instead gives us the MDC resources availability rather than the chemo availability. You'll notice if we send an appointment to MDC, we no longer have to book a nurse. In MDC, they just book to the chair. So for infusions, we just book to the chair as well. There's no restrictions. Well, it can't go in a lab draw space, but it is booked just like any other MDC, like a red blood cell transfusion or a port draw or any of the other MDC type work. So this workflow follows how to do exactly what I just showed you, how to take a request from the BCC VA chemo location and send it to the MDC location for booking instead. I think that's everything I have in my brain, almost.
That's a lot in your brain, Jill.
I know. I know.
Sorry, would it be the same scheduling clerk that's booking into the MDC slots as the one for the chemo chairs?
Sorry, are you asking who would do it?
Yeah, would it be the same
clerk? I don't know who does it today. I don't know if the chemo clerk calls the MDC clerk and says, hey, I'm sending a patient over. I don't know that particular, I mean, technically either one could do it, right? The chemo clerk could book into the MDC or the MDC could find that request and book it themselves. I suspect it's the chemo clerk that does it.
Okay. Thank you.
Any other questions off the top of your head? Anything I haven't covered that you've thought, are we missing anything, do you think?
There's one question, Jillian. I was writing last night, and there was one question I have. So just give me a minute. I'll find it. There's one thing I was going to ask you. I just have to find it in here. Okay. Give me a second. If other people are. So when they're assigning a BC, way back to the first one, for the new request, right? They're going into the request list. They're assigning a BC chemo booking date, right?
Mm-hmm.
So you said there's a matrix they have on their wall.
Mm-hmm.
Something in my notes. I was a little bit confused about that. So, because I was looking at your screenshot, if today is, then it says CBC is running on earliest date possible. Is that like run daily, or is it, or where do they get that from? Or is that like part of do they always have that Chemo Smart book open, or?
Yeah, so this booking date matrix is offline. And it's my proposal to BC Cancer that they have this chart created. Whether or not they do that or not is up to them. We know that we can't limit the number of patients that are assigned a booking date on a day. And we know that we can't limit the number of patients that are assigned specific reserved capacities in a day. And we know that we can't close the list. So currently, they can close their booking list. So if they know that they're running Chemo Smart Book on November 2nd, they will close the list on that day. And that means that nobody can add any more patients to that day. And we don't have that ability. So this booking matrix just kind of reminds the clerks what those limitations are, what those parameters are. So they know that if today is February 19th, they know that they're running Chemo Smart Book for March 2nd, that they can't assign any patients to any booking date before November 3rd, because everything before November 3rd has already been gone through Chemo Smart Book. It's already been assigned dates. It's already been scheduled. So they can't assign it that date. And then, so on November 3rd, the most number of patients that should be assigned that November 3rd date are 30 patients, or whatever number BC Cancer determines. Yeah. At Vancouver, it's going to be 85. At Prince George, it'll be 25.
Yeah.
And then beyond that, the reserved capacity. So how many reserved capacity slots are they allowed to use on that day? So this chart says they're allowed to assign 5 clinical trials reserved capacity slots. So this is just, the reserved capacity is just for Vancouver. They're the only ones who use this. So this is my proposal to BC Cancer, that they have a chart like this to help their clerks remember what the rules are as far as scheduling.
Okay, so I think I just went in and I just put it as pre-established BC, I think I put down systematic, I'll change this a little bit later. System therapy clinic clerks should follow the same established BC guidelines for booking dates or finding dates in from, Chemo Smart, but like they're already established, so we don't have to teach them or anything.
Right.
Just follow their current guidelines. That's how I went around it.
Yep. And I do say that a lot. I've said that a lot in our design and validation sessions, right? There's a lot that we're doing that's the same as they do today. And I say that you're using the same parameters you use today to determine when you're going to book that patient. We're not changing the rules at all. We're just applying them a little bit differently. That's all.
Yeah. So they're actually just, I'm just going to put it like, well, I'm going to send everything to you once I get a draft there, right? Mm-hmm. So they go in and that's actually that offline booking Chemo Smart Book. They can go in and then I'll change it, okay?
Okay.
Yeah, thank you. That was the part actually that I find it kind of confusing, was this whole going into the Chemo Smart Book. I thought actually, for some reason, I thought they may have access or something. I got mixed up there last night. So that, but today it clarified things. Think when you went in through, you said they already know. We don't teach anything. That's a good. I like that from training perspective.
So then beyond this, this workflow, so for me, this is all one workflow with a bunch of different tabs. My intention is to keep it this way. And then for Go Live, I plan on having another document, a troubleshooting document. Now, I know through having St. Paul's Go Live and through a bunch of testing, there are some quirks and things that can happen that might not go 100% according to plan. And so my plan is to have a troubleshooting document that is very similar to this, where each tab might have a specific type of thing that can go wrong that will work for us to step through the steps of remediation. So how do we fix an issue once we come across it? So I'm trying to keep a running log of all of the things that I know that might go wrong. Like, what if they do use the no-show functionality? What do we do? What if they check out a patient? What if all of the what ifs? And then that will help us, if Sam, probably you as much as me, during Go Live and after Go Live, will help us kind of step through some of those troubleshooting steps without having to come up with it on the fly, because that's what we did at St. Paul's and it was really hard. So if we know of certain scenarios that might happen, then we can have a document like this that will help us step through all of those issues.
Yeah, that would be great.
Yeah.
Really great.
All right, so how are you guys feeling? We've had 2 sessions. Do you want to set another session aside I don't have anything like as far as a presentation to show, but to ask questions, or do you want to just do it ad hoc as you go through your work and you come up with questions?
I definitely need to spend some time working through these workflows, which is
Okay.
what I have time for next week. So I'm sure I'll have questions from then. I don't know if anybody else has time or what they're going to do to kind of tackle it. I mean, Amy has less to do with it than I do, so I'll probably have more questions. But maybe another meeting. I'm not sure. Right now, I don't have an idea of what questions I'll have.
Why don't you go through what the work you need to go through, and if you want to set up a meeting, just send me a request. If it's a quick question, you can just ping me and we can just talk on Skype.
Yeah.
Okay.
Yeah. So, Jillian, I'm gonna, because I sort of wrote the first part, for the new patient. That's all I wrote so far. So as I'm writing them, I'm probably going to be asking questions. So I'll try to limit them to 1 email per day.
Okay.
There, unless it's like something really going to stop me. And I tend to work later in the evenings, rather than early in the morning, because when I have the meetings and stuff. So it might be a good idea, like, so you're not, when you do the draft, there's tons of stuff for you to do as you go along. So we might set up something a little bit later.
Okay.
Sounds good to me. Let me go through this and at least have a rough draft version of it.
Okay. Sounds good.
Okay.
And
all right.
Feel free to include me on any of those emails. Just CC me, because that way, in case we're not asking the same questions.
Yeah, or I might miss some. Sometimes I just miss.
And it's going to be the same thing for me, so I'll include you just in case, and maybe it's something we didn't think of.
Yeah, I would really appreciate that. And then did you want me to send any drafts or anything I have as I go along, or?
Absolutely, I would love that.
Yeah. Okay. So, probably by Monday morning I'll send you something. Okay.
Okay, sounds great.
Monday afternoon, because I have a really strict deadlines for this, so it's sooner than later.
Okay. And if I can help you in some way with those deadlines, let me know.
Oh, well, that would be your heaven right now.
I mean, I know a lot less about this stuff than you do, but even if it's just dirty work, you're like, can you put this into a document for me or something like that? I'm happy to help.
Actually, Jillian and I might send you a couple of help topics. We've actually already done a couple of help topics on chemo. So rituximab and those, I was just going to go in and appointments reviews. I have something. There's a whole bunch of stuff I actually already have on oncology as well.
Okay.
I sent those to you for review for it's not exactly what Jillian this workflow.
Yep.
Just to get you familiar.
Absolutely. My direction is to become the expert in our small team on BC Cancer. So I figure anything that, even if I'm helping you work through this stuff, is definitely helping me get knowledge. So it works for both of our benefits.
You don't know how much that means so much to me. Thank you so much.
No
I'm so
worries.
appreciative of that. All right. So I'm going to probably in the next 10 minutes, I'm going to send you a couple of help topics. So then you can that I've already done if you want to practice. Okay.
Sure. Absolutely.
Yeah.
Thank you so much.
No, it's different. We're separate entities. Yeah.
Sorry.
All right, guys, I'll let you go.
Thank you, Jillian.
Thank you, Jillian.
Okay. Thanks, guys. Have a good
Bye, guys.
weekend.
You too.
Okay. Talk soon. Bye.
Bye. What was it, Amy, you were saying? Was it Amy? Never mind.
I didn't hear anything. I'm not sure. She typed it in if that's what she meant.
I have dropped off. No, I heard somebody in the background, so I wasn't sure.
Oh, she's probably just saying goodbye, I imagine.
Oh, okay. Yeah. So there's a couple of, you got 2 minutes here?
Yeah, absolutely.
Can I present my desktop?
Yep, go ahead. Are you able to?
Yeah, I think I am. Okay, I'm going to just show you a couple of things. I was actually going to, okay, it should be coming up soon. Right now it's blank, but I'll pull over the help topics, okay? Okay. Do you see my do you see it?
I do. Sorry, I mute myself in between. So.
Yeah, that's okay. That's fine. So see if you go, like I'm on the scheduling page. Okay. The faster way to find them is if you go on the scheduling page where it says specialties. Okay. And see where it says oncology topics. So I was actually going to go in and because these are done with Jillian. I did, right? So one of them up here is it's for MS OPD. We did book oncology chemo infusion appointments. Come on, let's open. There we go. So it's different request lists, but it's not exactly the same, but it does tell you how to change the chair time, and it goes through it. This is like very simplified version. Request list, inquiry, and all that stuff, wonderful stuff there. But the other one is I actually did on a rituximabs there. Review request list. Where is it? Reschedule. Review and reschedule. So there's that review and reschedule infusion appointments. This might be need to update it. That's not a good one. There's ones that we did rituximab. There we go. This is a really good one because it goes through the power plan, how to book rituximab with chemo. Then it tells you, if you schedule it on the same day, and then if you schedule rituximab same day as that, and then if you go through, do all that wonderful stuff, and then if it's done on the separate day, then it tells you that. So I was actually going to use this one partially if it's still valid. There's a few different things there. Use MSPOP checkup, yeah. Yeah, those are the basically, reschedule. This one's a good one too. So this is the one where she was talking about if they have to be rescheduled after they checked in. So the oncology nurse has to do stuff. Then this is what the clerk does. And up update BC there. So this is what there. So I was going to actually use this one as well because it's on one of the workflows as well. So have a look if you want to, and see what you think.
Okay. So did you just want me to give feedback on it too, or just find any errors, that sort of thing, or just all of it?
If you find any errors, if you want to, that'll be wonderful.
Yeah, I'm happy to do that.
Yeah, if you do that, but I think honestly, it's going to have to be a online module because there's so many things. It's going to be too hard to train in the class.
Yeah, that's fair.
There's so few of them. So if I could get Jaden, I don't mind developing all the training material and stuff. So if Shannon can get Jaden to, because he has the background to develop the material, huh?
Absolutely. I want him to do all the learning stuff. He's already so experienced at it.
The best way to learn is to actually develop the training material, so I'm actually going to do all the actual work. So he just goes and copies my screenshots and on that. But he's actually really good at it. He's actually quite bright because he did something for me and he's happy to do it.
So,
is that your partner in the background?
Yeah, that's why I mute. She's quite loud.
Okay, sorry, I thought that was Amy. Sorry, I thought that was Amy. So that's fine. So if I can get Jaden to do a radiation 2 online modules, develop them. I don't mind developing all the training material. I'll work with them because that's the only way I can see we can work through this.
Yeah, that sounds good. I'm not sure when he's coming to the team, but I'll start on this stuff, and I'm sure we'll be pulling him in as soon as he gets here.
Yeah,
he and I are going to be tackling it.
And then also, just go through there. You can add your own patient. So scheduling, patient scheduling. I'll send you a screenshot in a few minutes. Scheduling Cora, scheduling Violet, scheduling Suzanne, scheduling Miranda, scheduling Demo. Those are my patients. I actually put in orders for chemo yesterday morning, so I can go practice and use them for that. I think you guys have couple of scheduling patient names there as well, right?
Yeah, I created some for I don't even remember what it was. For some sort of document, but they've never been used by anybody in the year, so I just adopted them and started using them. Because I think they were for a skill sharpener.
Yeah.
But clearly no one's ever run it, so.
Okay. So were you able to, do you know how to put an order? Do you feel comfortable putting an order in for chemo?
The only time I've done chemo order so far was from SIT script.
Uh-huh.
So I'll either look for a SIT script, or if you have another resource that shows me how to walk through it, I'll pretty much do that. Because comfortable off the top of my head, no, I've never.
Okay, so do you want me to, what I could do is in half an hour,
Yeah, so we do have
do you want me to go in and put a couple of patients in for you for the order?
It does.
I mean, if you have time, sure, but it sounds like you're pretty busy.
Can you do that for me? I'm more than happy to. I'll put a couple of patients for you.
Okay.
And what patients?
I'll just create 2 with my name on it, so I don't mess up the scheduling pool.
Okay. So just send me the list of those patients and I'll do them today, okay?
Sounds good. Awesome. Thank you.
I so appreciate it.
Okay.
Yeah.
Bye.